Hello and welcome. Today, we're discussing a condition that's often misunderstood and rarely talked about: fecal incontinence. It can significantly impact a person's quality of life, and our goal is to provide a clear and informative overview. So, what causes fecal incontinence? The etiology is quite diverse. It can stem from muscle damage, often during childbirth, which weakens the anal sphincter. Nerve damage, perhaps due to diabetes, stroke, or spinal cord injury, can disrupt the signals controlling bowel movements. Other contributing factors include chronic constipation leading to fecal impaction and overflow, inflammatory bowel disease like Crohn's disease or ulcerative colitis, and even certain medications or surgeries. Let's delve into the pathophysiology. Fecal continence is a complex process involving several components working together. These include the internal and external anal sphincters, which control the passage of stool, the puborectalis muscle, which maintains the anorectal angle, and the sensory nerves in the rectum, which signal the need to defecate. When any of these components are impaired, the ability to control bowel movements is compromised. Damage to the sphincters reduces their ability to contract and hold stool. Nerve damage can disrupt the communication between the brain and the bowel. Reduced rectal capacity or impaired rectal sensation can also lead to urgency and leakage. Fecal incontinence affects a significant number of people, but precise epidemiological data is challenging to obtain due to underreporting and social stigma. It's estimated to affect millions of adults in the United States alone, and the prevalence increases with age. Women are more likely to experience fecal incontinence than men, often due to childbirth-related injuries. It's also more common in individuals with neurological disorders, diabetes, and those residing in long-term care facilities. The signs and symptoms of fecal incontinence can vary greatly from person to person. Some individuals experience occasional leakage of stool or gas, while others have a complete loss of bowel control. Other symptoms may include urgency, the sudden and intense need to defecate, soiling, staining of underwear, skin irritation around the anus, and emotional distress, such as anxiety, shame, and social isolation. The severity of symptoms can range from mild to severe, significantly impacting daily activities and overall well-being. Diagnosing fecal incontinence typically involves a thorough medical history, physical examination, and several diagnostic tests. The doctor will ask about your bowel habits, diet, medications, and any underlying medical conditions. A physical exam will assess the strength and function of the anal sphincter muscles. Anorectal manometry measures the pressure in the anus and rectum, providing information about muscle function. Endorectal ultrasound uses sound waves to create images of the anal sphincter muscles, identifying any structural damage. Other tests, such as a colonoscopy or sigmoidoscopy, may be performed to rule out other conditions. While a one-size-fits-all approach doesn't exist, we can broadly classify fecal incontinence by underlying causes, for instance, bowel disorders, muscle damage, and nerve issues. Urge fecal incontinence is caused by a sudden, compelling need to defecate that cannot be controlled. Passive fecal incontinence, also known as seepage, involves leakage of stool without any awareness or urge. Overflow fecal incontinence results from chronic constipation and fecal impaction, where liquid stool leaks around the hardened mass. Treatment and management strategies for fecal incontinence are tailored to the individual's specific needs and the underlying cause of the condition. These strategies may include dietary modifications, such as increasing fiber intake and avoiding foods that trigger symptoms. Bowel training can help regulate bowel movements and improve control. Medications such as antidiarrheals or stool softeners may be prescribed to manage symptoms. Pelvic floor exercises like Kegel exercises can strengthen the anal sphincter muscles. In some cases, surgery may be necessary to repair damaged sphincter muscles or address other underlying conditions. Biofeedback is another option where a therapist guides individuals to consciously control sphincter contractions, improving muscle strength and coordination. While not always completely preventable, certain measures can reduce the risk of developing fecal incontinence. Maintaining a healthy weight, eating a balanced diet, and staying hydrated can help prevent constipation. Practicing good bowel habits, such as avoiding straining during bowel movements, can reduce stress on the anal sphincter. Women who have given birth can benefit from pelvic floor exercises to strengthen the muscles after delivery. Managing underlying medical conditions, such as diabetes and inflammatory bowel disease, can also reduce the risk. The prognosis for fecal incontinence varies depending on the underlying cause and the effectiveness of treatment. Many individuals can achieve significant improvement in their symptoms and quality of life with appropriate management. Recent research has focused on developing new and innovative treatments, such as sacral nerve stimulation and injectable bulking agents, to improve sphincter function. Ongoing studies are exploring the role of gut microbiota and its impact on bowel control, paving the way for potential future therapies. The field is constantly evolving, offering hope for those living with this challenging condition.